Great. Well, thank you very much, Naomi, for that brilliant introduction. You couldn't have set us up any better. I'm Christine Farquharson, that's Gabriella Conti, and with our co-authors Sarah Cadden and Rita Ginja, we're the authors of the report that IFS is releasing today on the health impacts that SureStart has had. So Naomi's taken us through a lot of this, but what is SureStart? It's one of the major programs for early intervention in England. They try and offer a one-stop shop for children, for families with kids up to the age of 5, bringing together a whole range of services, too many really to fit on the slide, but including health, education, childcare, support for parents' employment. Of course, more recently, the context has been really rather different. It's been one of cuts, consolidations, and closures of the centres. You can see that there's, I think, no better way of seeing that, actually, than looking at spending on SureStart, which goes from around £600 million in 2001, that's in today's prices, peaks at about £1.8 billion in 2010, when it makes up a third of government spending on children under 5, and then since then has fallen back really in a mirror image of what it did before, right back to where it was before at around £600 million, funding cuts of 2/3. That's the national picture, but local authorities have responded in really different ways to these overall funding cuts. Some places, like Bromley, like Oxfordshire, where David Cameron's mother was, have chosen to close the majority of their children's centres, and other local authorities have instead kept many of the centres open, but cut back on the services that are available through them. So it's a service consolidation and service cuts rather than necessarily centre closures. And we're really lucky today to have Kathy Silva to talk a little bit more about that later on this morning. So these cuts have not always, well, these cuts have almost always actually been quite controversial. I think this is probably still my favorite protest placard, which is "Hands off SureStart, what next, our souls." So people did care a lot about this program. But what's really interesting for us at IFS and for the people in this room who believe in evidence-based policy is actually this is quite a turbulent history. And like Naomi was saying, a lot of the time these decisions were being made before the best evidence was really available. It's frankly pretty astonishing to me that SureStart's now entering its 20th year, and this is one of the first studies that looks at the impacts it's had on children and their families over a sort of substantial period of the time when it was operating. Of course, at the same time, this seems to be now a more active area of policy than it was before. So the Education Select Committee recently said there seems to be little strategic direction to government policy on the early years. The government has recently commissioned the Early Intervention Foundation to do some more research on early years services and particularly around children's centres. And of course, we wouldn't be an IFS presentation if we didn't say that the forthcoming spending review, whenever it decides to come forth, is a chance to shape public policy. What we'll talk about today is how SureStart has affected the health of children and their families during the period when it was rolled out and operating at scale, so about between 1999 and 2010. In addition to that kind of big overarching question, we want to also understand whether some groups are benefiting more than others and how cost-effective SureStart looks as a way of promoting children's health. We're focusing here on health outcomes and particularly on hospitalizations, obesity, and mothers' mental health. And what's really unique about the findings today is previous research has looked at the impacts in the very earliest years of the program or has taken really good descriptive evidence about the people who use the centres, but we're the first to really look over a longer period of time at the causal impacts that SureStart has had on children and their families. And we're going to do that by using some of the variation from this long rollout that Naomi's already talked through. So we've heard a little bit about how this looked from the civil servant's perspective. I can show you a bit about how it looked from a graphical map perspective. This is England on the left and London blown up on the right. And the darker areas are more disadvantaged local authorities. So these guys are ranked by their 1998 Index of Local Deprivation, and the darkest green areas are in the bottom 5% of the national ranking. You can see that the year after SureStart the first local programs opened, these red dots are really very concentrated in those darkest green areas. So this is exactly that SureStart was being rolled out first in these disadvantaged communities that maybe you worry about visiting in your taxi. By 2004, the government pledges a children's centre in every community, and you can see that it's starting to populate a bit more of the map, but still quite concentrated in those disadvantaged areas. And even in 2006, a couple years after that Children's Center Everywhere announcement, the poorest 30% of neighborhoods still hosted over 80% of SureStart centers. It was only after that point that the program started to fill in and really get into the richer, more affluent areas. And you can see here, it looks, since it's a health outcomes presentation, it looks a bit like England has chicken pox. But the centers really did go everywhere. This was a fast rollout for about a decade of time. We're looking here not just at the number of centers and where they were, but we care about the number of people who were potentially accessing them. So we look at the local area characteristics that predict higher SureStart coverage, which we define as the number of centers per 1,000 children aged 0 to 4. That's the eligible age range for SureStart. And in line with policy guidance and everything that you've already heard this morning, it's pretty clear that SureStart was rolled out first in the most disadvantaged areas. But we find in our statistical model that other things also seem to be good predictors of SureStart. Lower employment rates, fewer English as additional language students, and a county or borough, so that upper tier council, controlled by Labour, who were in power nationally, all of those things seem to predict higher SureStart coverage. It's not causal, but what this does suggest is that, probably surprising nobody, the program was rolled out in line with the policy guidance that was written, but there were other things that people were paying attention to as well. Ultimately, though, there's lots of variation between even quite similar areas in the level of access to SureStart that they had and the speed of the rollout. So this kind of shows you what that looks like. The dark blue line shows you how coverage of SureStart changes based on the year and month of birth of a child. And so for a child, we calculate the average coverage in every month, and then we average that over their first 5 years of life to give a sort of single measure of how much access to SureStart a kid has. You can see that this goes from about 0 in January 1993, which I promise I didn't pick just because that's when I was born, up to about 1 center per 1,000 children aged 0 to 4 by the time the program was operating at its peak in about 2010. But these light gray lines in behind that show you that there's a lot of variation across the different local authorities in England. Some of them are, really getting to about 2 centers per 1,000 kids or 1.5. Some of them are much lower at sort of 0.5 center per 1,000 kids. And this is exactly the kind of variation that we're going to exploit. So we're comparing here children who are born earlier or later in the same very small neighborhood. When I say very small, it's a lower super output area that has about 1,500 people in it. So these are really, really like a couple of city blocks small. The kids who were born earlier or later have different access to SureStart based on where they were born and when they were born. So in that same neighborhood, the coverage tends to increase over time. Our methodology lets us strip out both permanent differences between these small neighborhoods, as well as national differences between years. And so then we can look at children and families' health outcomes and relate those back to the access to SureStart that they had. To do that, we're going to look at 3 different outcomes: hospitalizations, obesity, and mother's mental health. And we're considering here the impact of providing access to SureStart at a level of about 1 center per 1,000 children, so that kind of England average when it was fully rolled out. It's really important to say that we're not looking here at the impact of actually choosing to use the SureStart centers. So this is the impact of the government coming along, deciding we're going to put a SureStart center in this neighborhood. Can't really force people to go to it, but here's what the total impact on everyone who could go is going to look like. For hospitalizations, we use the hospital episode statistics, which is a great data set that has every single hospitalization in England between 1997 and 2014. Don't worry, we're not allowed to identify anybody in that data. And we look at admissions during primary school, so from ages 5 to 11. Particularly, we care here about the probability that there was at least 1 admission in a neighborhood, sex, month, and year of birth cohort. So kids who were born in October 2004, who are boys in a very small neighborhood. That's what we care about. What's the probability that one of them gets admitted at age 5? When we look at that, you can see that at ages 5, 6, 7, 8, a little bit at 9, we don't actually find any impacts that are statistically different from 0. So these vertical bars tell you the confidence intervals, and when they cross that 0 line, it means we can't be confident that the effect isn't just a result of chance. But if you look out at the older ages, we see really big impacts. At age 10, the probability of hospitalizations falls by around 12% of its pre-SureStart baseline, and at age 11, that's around 18% of the pre-SureStart baseline. That's admittedly hard to interpret, but to give you a sense of scale, that's around 5,500 hospitalizations of 11-year-olds prevented each year from offering one more center per 1,000 kids. That's a big impact. We can look at who is experiencing the biggest benefits. So there's some evidence here that boys are getting bigger benefits than girls. You can see from the stars along the top whether the difference between the two is significant in a statistical sense. And you can see from the stars on the lines themselves whether that effect at that age is, we can be confident is different from 0. But while there's a bit of a difference here by sex, the really big differences come when we look at disadvantage. Children living in the richest 30% of areas don't have any effects that are statistically different from 0. And at those older ages, that's about as precise of a 0 as you're ever going to get. We're really not finding much evidence of a benefit for them in terms of their hospitalizations. It's a completely different story when you look at kids in the poorest 30% of neighborhoods who see falls in their hospitalizations of almost 20% off of the pre-SureStart baseline by the time they're age 11. And what that means is actually SureStart seems to have helped to reduce inequalities in health, at least in terms of hospitalization rates, between these poor and rich areas. We estimate that at age 11, providing this level of SureStart closes around half the gap between the poorest and the richest neighborhoods. We can also look at SureStart's impact on hospitalizations for different causes. And this is interesting in and of itself, but it also starts to help us think about how SureStart might be delivering some of these benefits. It's a really multifaceted program. There's a lot of services, and I can't stand here and tell you exactly what it was that led SureStart to have these benefits. But we can look at some of the results and think a bit about what would be consistent, at least with the effects that we're seeing. So the first cause that we look at is respiratory illness, which is one of the biggest reasons for hospitalization in this age. And there we don't really find any significant results. That doesn't seem to be a big driver. When we look at infections, at age 5, we do find statistically significant results. 5-year-olds, our hospitalizations are going down by around 27%. And this is very consistent with a lot of other evidence that talks about the immune hypothesis. So kids who go to SureStart are going to childcare services, they're spending time with lots of other kids who have lots of nasty germs with them, they're getting sick, but they're building up their immune system so they get less sick later on. Kids who don't have access to SureStart go to school at age 5, and that's when they start to experience all of those nasty bugs and sicknesses that anyone who's a parent in the room I'm sure knows very well. But then those benefits tend to fade out as the kids who are going to school catch up with the kids who went to SureStart. We can look at hospitalizations for preventable causes. So these are causes like asthma, which the NHS thinks shouldn't need to be treated in hospital, as well as things like gangrene, which the NHS and everybody thinks probably just really shouldn't be happening in England in the 2000s. You'll be happy to know it's pretty rare. We find that these effects mirror the sort of overall impacts that we see, but they're not statistically significant, and the actual numbers underlying this are small enough that this isn't going to be a major driver of our results. What does look like it's important is admissions for external causes. These are things like accidents, injuries, broken bones, and these fall statistically significantly at every single age, with bigger benefits as the children get older. We can unpick those external causes a little bit more. We look at poisonings, there doesn't really seem to be very much. Accidents, maybe there's something, but it's not statistically significant. Really where this is coming from is injuries, and in particular fractures. So this is kids breaking their bones, sometimes banging their heads, particularly at younger ages. And we find that these injuries account for about 1/3 of the total number of averted hospitalizations at age 11. This is really interesting when we think about mechanisms, because whatever the mechanism you have in mind, it's got to be something that has long-lasting benefits for children. It can't be that the SureStart Center works on a kid, it does its intervention, job done, no more long-term impact. So these have to be things that foster changes. Some potential outcomes would be things like maltreatment, parenting, children's behavior. We know that behavior is one of the biggest is very highly related to hospitalizations and to injuries. And so these are the sorts of long-run mechanisms that you have to have in mind in order to make sense of these results. And now Gabriella is going to talk about the impacts on some of the other outcomes that we've looked at, as well as the cost-benefit analysis.
Thanks very much, Christine. So we saw big impacts on hospitalizations, but as Christine mentioned previously, we also looked at two other outcomes. So the first outcome we looked at is obesity, because there is already existing evidence that early interventions can have reductions in obesity. And also some of the services provided by SureStart could impact obesity in children. We used the National Child Measurement Program, which measures the height and weight on children, and we used data between 2008 and 2014. We looked at all children in reception years, so approximately age 5, and we have a big sample. We have around 600,000 children per year. And I have to say we are very grateful to Vicky Copley at Public Health England, who ran the code that we provided to her to run the data. We didn't have direct access to the NCMP. What we find in this case, there is no evidence of a significant impact or SureStart of any of the obesity measures that we looked at, which are body mass index or the dichotomous measures of overweight, obesity, and clinical obesity. SureStart could also have improved the outcomes for children by improving maternal health, in particular mental health. So we also looked at this outcome, and we used a panel dataset which covers many years called the Understanding Society, and we considered years between 1993 and 2014. Here the sample is a little bit smaller than one we had for the hospitalizations and for the obesity, and in particular we look at the access for SureStart for the eldest child of the mothers that we observe. We use a quite well-used measure of maternal mental health, which is the general health questionnaire, but also in this case, we couldn't detect any significant impact on maternal mental health. The estimates are very imprecise because our sample size is quite small. So after we have looked at these three outcomes, can we say something about whether SureStart was cost-effective? So we performed quite a simple cost-benefit analysis, and we compared the benefits coming from averted hospitalizations against the cost of providing SureStart. So which benefits we considered? We considered three types of benefits. So first, reduction in hospitalizations could have a direct cost savings to NHS. Why? Well, because hospitalizations in children are very costly, and now they are being averted thanks to SureStart. And in particular, in this cost, we included the reduction in hospitalizations for infections that Christine showed occur at age 5, the reduction in hospitalization for injuries between ages 5 and 11, and we also extrapolated up to age 18 using quite conservative assumptions, and we included separate costs taken from the NHS resource use cost for pediatric fractures, so things like broken bones, head injury, distinguishing between intracranial, so things like traumatic brain injury, and non-intracranial, so like concussion of the head or even a broken nose. Then we consider indirect saving to children's parents. So for example, lost days of work because the parent has to take care of the child who is hospitalized. This was also averted by SureStart. And some of the hospitalizations, especially those for head injury, can incur long-term cost. In particular, we took estimates from the literature on the proportion of hospitalization for fractures and for head injuries, which could be attributed to child maltreatment. And those we look at our data, and we computed the proportion of hospitalization per head injury, which can be due to traumatic brain injury, which has severe long-term cost. And we use cost of child maltreatment and traumatic brain injury from the best available evidence. For the cost of SureStart, so here we are overlaying a graph on total spending that Christine shown before by computing a measure of cost per child that we computing by dividing the total spending by the number of eligible children per SureStart per year. So you can think of our cost measure as really like the average expenditure per eligible child that the government incurred. And when we average across all the period we consider 2000 up to 2014, this amounts to £416 per child. So how we then compare the benefits and cost? We used that number, 416, and we looked at the cost for the government of giving SureStart to an average cohort of eligible children for the full childhood. So think about like 500,000 children, which is the average cohort size of eligible children in the period considered, and consider of covering it with SureStart, giving access between 0 and 4. That's gonna cost a little bit over 1 billion, so that's quite a big number. When we consider all the cost of hospitalizations averted by SureStart, our estimate comes up to be 65 million, which is 6% of the cost of the government. So only by considering hospitalizations averted by SureStart, we are able to recover 6% of the cost. And if we look at the breakdown on this averted cost, we see that the bulk of them, 83% of them, comes from the cost in the lifetime consequences of things like head injuries, which are being averted. But also a significant component comes from the immediate savings to NHS from the averted hospitalizations in children. Of course, one important thing to consider is that, as Christine mentioned, we can't really pinpoint the mechanism through which SureStart reduces hospitalization. If this is due to things like improvement in child behavior, in child prosociality, improvement in parenting skills, we know that those have significant benefits which are not accounted for here. In addition, we only looked at one outcome among all the possible outcomes that SureStart could have improved. So we want to know more, and this is just the beginning. So in ongoing work at IFS, we're looking at impacts of SureStart using the same strategy that we have used in this report on a variety of other outcomes, such as other measures of child health. Here we only looked at hospitalization, which are really extreme conditions. We want to look at what happens to GP services, GP visits, more immediate conditions. More work on maternal, especially physical health, parental employment, academic outcomes and behaviors. There is ongoing work using the National Pupil Database. What happened to children in foster care, children in need? What happened to family violence and crime? Did SureStart help reducing youth crime? So this is all work which is hopefully going to come out soon at some point in the future, so stay tuned. So what we have learned so far? Well, our report provides the first causal evidence of the health impacts that SureStart had over the entire period when it was rolled out between 1999 and 2010. We found big benefits, a significant reduction in hospitalizations among children by the time they finish primary school, which amounts to an 80% reduction at age 11. Most importantly, the benefits are stronger for disadvantaged children, so that the gap between the poor and the rich is halved. And we do find reductions at all ages we looked at between 5 and 11 for injuries, which amounts to up to 30% at age 11. These are quite big numbers. As mentioned, we find no impacts on obesity or maternal mental health, but given some data limitation, we shouldn't really consider this absence of evidence as evidence of absence of impacts on these outcomes. And lastly, the benefits of the program for only averted hospitalization, so one outcome among many, covers around 6% of the cost of the program. So where does this leave us today? Well, we have two questions for policymakers. The first one is, given the substantial health benefits that we find, is the current level of cuts appropriate? We do find that the SureStart model significantly improved children's health. As Christine mentioned, we wouldn't be IFS if we didn't say that the spending review will offer a chance to talk more about spending of early intervention and prevention. That's a conversation that it has to be made. Second question, we can't go back exactly to the peak of spending. That's going to be a long way up. Then, if cuts have to be delivered, how should they be delivered? Well, we show that SureStart mostly benefited children in poorer areas. We don't know whether this is due to the characteristics of the centers in those areas or to the characteristics of the children and the mothers and the fathers who use those services in those areas. So that's an important question to answer, and we will be very happy to answer if data on attendance to SureStart Center were made available by local authorities. But for now, what we can say is that our funding suggests focusing limited resources on poorer neighborhoods who benefits the most from them rather than spreading them more thinly. Thanks very much.